Welcome back, everybody. This is Amanda Furlant, physical therapist. We are continuing on our post-operative seminar series, teaching and introducing the clinical anatomy related to articular cartilage. So today we're going to focus on articular cartilage and understanding the anatomy, as well as understanding how that will affect our treatment for patients who have articular cartilage injury, as well as possibly following surgery of articular cartilage. And you would be surprised at how many of your patients this probably applies to. So we're going to introduce that today. And I'm starting here with a slide that we finished with the introduction. And what you'll see here is we talked about the different healing times for patients with different types of injury, depending upon the tissue that we're talking about. And so if you remember, we discussed the fact that things like muscle have a lot of great blood flow. And so muscle and tendon tend to heal more quickly than ligament and articular cartilage. And bone also heals very quickly because of good vascularity, so good ability to have blood flow come in and heal that tissue. So when we're talking about articular cartilage, we want to consider the fact that it can take anywhere from 2 months to 2 years to heal following repair. And so this might be why we do things like a knee replacement or a hip replacement, because that cartilage may not be able to repair itself. So let's start with introducing the clinical anatomy of articular cartilage. And what we need to recognize is that that avascularity really does lead to limited ability to repair. Articular cartilage also has decreased nerve. So it's basically what we call aneural. And so that's why oftentimes when there's damage to articular cartilage, your patients may not actually report any pain. And so it makes it a little bit harder than to recognize when there's injury, because there is no nerve endings that would lead to a pain response. Also, because there is very little vascularity, the nutrients that we get actually come from the synovial fluid. So there's fluid around the cartilage that provide us with nutrients. And the way that we're then able to heal and improve on that cartilage is through loading and unloading. And we're going to talk, basically today's entire talk is about how we can do that. Loading and unloading in a very easy way will allow for healing and repair and health of our cartilage. So what cartilage is made up of is primarily water. About 10 to 20% of the matrix is made up of type 2 collagen. And you will notice as we talk about things like ligaments and tendon that collagen makes up a large amount of these connective tissues. Unfortunately, with cartilage, collagen makes up that tissue, and with cartilage there isn't a lot of it. But it does help to increase the tensile strength. So it's helpful because it keeps it stronger, but it doesn't allow for a huge amount of the matrix. So what we have to recognize is that cartilage on the ends of bones is very thin. It's only several millimeters thick. Other things involved in the cartilage are going to be chondrocytes, and you'll see that it's only less than 10% of the volume, but it is what is responsible for producing and maintaining the matrix. So those chondrocytes are really, really important to help us be able to keep the cartilage that we have. That extracellular matrix is basically a collagen network that, as we said, consists of type 2 collagen and is there to help with tensile loading. And then the vast majority of the cartilage tissue is made up of water. So 65 to 80% is made up of water. And you'll see here you have this nice picture that shows how we have 4 zones of cartilage. So the very outside we call the articular surface. We then have a middle, which is kind of the transitional zone, and then the deep zone, which has a little bit more calcification, and then we get into calcified cartilage and then subchondral bone. So remember, cartilage, when we think about it from an orthopedic standpoint, is directly related to bone, and it sits on top of bone. And we're going to talk about its role with helping us with movement in a little bit, but recognize that it directly attaches to our subchondral bone, which then goes to cancellous bone. And the function of articular cartilage is to be able to distribute load. And for those of you who might have done physical therapy for a while or understand anatomy, you'll know that we talk about things like the meniscus specifically, which is a type of articular cartilage in theory that helps to distribute load over the knee joint. And so the idea is that we have pressure from the ground up and from our body down that provides power through our joints. And the cartilage is there to help minimize friction and allow for load or power to move through our joints without any damage or any issues to those joints. And so it's transferring the load from one surface, subchondral surface, to another, and it absorbs the load and impact. So it allows us, again, to move effortlessly, if you will, through our joints. We also have the ability with this articular cartilage to use that synovial fluid to lubricate our joint. So we want to allow for good water. We want that water there to allow for us to minimize friction to the bone underneath the cartilage. The last thing we want is for the bone to actually be damaged or have extra friction or rubbing against the bone underneath the cartilage. We don't want that. And so our cartilage is made up of, it's what's called a biphasic material, meaning that at times the cartilage can be more solid, and other times there can be what's called a fluid phase. And so if you look down at the bottom of this slide, you'll see that with loading, those phases will change. If we have constant loading or pressure on the cartilage, then the fluid is going to flow out of the tissue. And then as we unload or recover, the fluid flows back in. And so the fluid is really there to help us take on the pressure. So again, that power that's coming from our body, coming from the ground, that can push through the cartilage, through the joint, it allows us to take that on through the fluid, through essentially the fluid phase. However, recognize that if we have constant strain or loading on that cartilage, then we actually go from a fluid phase into a solid phase. So we lose the fluid. It actually gets pressed out of the cartilage. And so we need to have an unloading or recovery time to allow for the fluid to come back into the tissue. So recognizing the nutrition is exchanged through that synovial fluid. And so we have that idea of compression and then unloading, and that allows for that fluid to come in and provide us with the nutrition needed to keep our cartilage healthy. And so as long as we have what's called reciprocal loading and unloading, then we can have healthy cartilage. And that's the most important thing that I want you guys to understand during this particular presentation, is that for cartilage to be healthy, it needs what we call reciprocal loading and unloading because of the type of tissue that it is. And so the other way you might hear this unnamed is what we call the pumping effect. And so because there is so much water in the extracellular matrix, then you'll recognize that the fluid can move out with loading and in with unloading, and that pumping effect, as we said earlier, actually provides the cell nutrition. It allows for molecules to come in and out and allows for the joint to stay lubricated. So as long as we're loading and unloading, then we have the ability to keep that cartilage nutritionally viable. Remember, there are no blood vessels, so there isn't the ability to get nutrition that way. And so it's really important that we keep some sort of ability to compress and decompress the tissue. So when do we start getting injuries? Osteochondral, what we call pathokinesiology. So what types of situations can cause injury to the cartilage? Oftentimes we see these issues to cartilage with high impact athletic activities. And so people usually younger are the ones who end up with significant tears in cartilage or possibly wearing down of cartilage. And this can happen again from high impact athletic activities like plyometrics, but it can also happen when there's some sort of malalignment or muscular weakness that causes one side of the joint to have more wear and tear than the other side of the joint. And so you end up with more loading and not enough time of recovery. Also, for some reason, it's more common in males, and I think this might be because there's activity level that's increased in men, especially men who are doing physical labor. But you'll also notice that recently there's an increasing prevalence of this type of problem in females, again, probably because of increased activity. The areas you're going to see this problem the most, so wearing down of the cartilage at a younger age, is going to be areas like the knee, the talus at the ankle, the capitulum, the femoral head, and the trochlea. And again, there's an increase of this occurrence in weight-bearing joints, so lower extremities. So now let's talk a little bit about the areas of the body where we see the most articular cartilage. And we're going to start with the upper body, where again, we don't usually see as much of a pathology with the upper body cartilage, but where you will definitely see issues might be around the humeral head, especially areas like the labrum of the shoulder. And so labral tears we would kind of put into this category. At the elbow, we're going to spend some time talking about the elbow. There's a good amount of articular or hyaline cartilage at the elbow, and a lot of different things can happen with injuries at the elbow. Fractures can lead to a lot of interesting extra bony growth and things like that, as well as injuries to the cartilage. So the elbow is kind of a unique joint for these type of injuries. Other areas that you might not think of where we have a good amount of cartilage would be our discs and annulus. So when you think of the spine and you think of getting an annular tear or a bulging disc or a herniated disc, this is actually cartilage that is being injured somehow. So we're going to spend some time talking about that, specifically with injuries that might require a discectomy, or a laminectomy, or even a lumbar fusion. And these can happen in the cervical spine as well. And so again, this is a type of cartilage that can be damaged. And I'm sure we've all seen this, seen patients with these issues with damage to this type of cartilage. Other places articular cartilage exists, we already kind of mentioned these. This is going to be, you'll see the distal femur, and as well as the hip. So the acetabular labral tear, this is at the hip. So again, the other labrum, we have the labrum of the shoulder, the labrum of the hip, and both of those can get injured. And then lastly, we look at the talocrural joint, where we have the talus having cartilage injuries as well. So we all know some of our amazing athletes And we know that these guys can get tears and injuries to their cartilage. But we also have a lot of our older people, a lot of our older patient population who will start complaining of pain. And sometimes those can be things like meniscal tears. Sometimes that can be osteoarthritis. So it can be any of those things that really involve articular cartilage. So there's 3 types of surfaces that we consider still cartilage, but can have injury. And the first one that we want to talk about are the chondrocytes in the matrix. And so we talked about how the chondrocytes, there's not a lot of them, and they are the tissue, or not the tissue, but the cells that can proliferate the most easily. So if you end up having an injury to the chondrocytes, then it's the least severe of all injuries. They can heal pretty quickly. As long as that matrix is intact, then you're most likely to not even know that you've had an injury. However, if you have articular cartilage damage itself, this is where we're going to have the holes. So it looks a little bit like this picture that we looked at here, where you're going to have holes in the cartilage. You'll see on the left there or on the right, and you might get little flaps or different types of tears in the cartilage. And again, the problem is new tissue doesn't necessarily come in and fill in this articular damaged tissue. And so you actually have to oftentimes do something else for treatment, such as a joint replacement. So this is where if you end up with a large enough bit of damage that isn't healed with some sort of surgery, then over years you might end up with osteoarthritis and require some bigger surgery like a replacement. You also can end up with damage to the subchondral bone. And you'll notice there that you're going to get some sort of inflammation. And really, when it gets down into the subchondral bone, you may actually have more blood flow to that bony area. And so you could get remodeling. You could actually get an improvement in the joint because that area does have better blood flow. And so you might actually have better healing. But unfortunately, it's really unknown. And so you may also end up with further degeneration if the blood flow, for whatever reason, to that tissue is not good. You'll also see here at the bottom that even if you do get healing, it takes about 24 weeks for that tissue to really start to look like your normal tissue. And even then, we're not sure that that tissue looks like the original tissue. So you may never end up with the cartilage and subchondral tissue area looking like the original. So when can these things happen? We kind of mentioned earlier that it can happen with athletes who do high impact activities or some sort of malalignment. Also, avascular necrosis oftentimes will lead to the injuries of the cartilage. And so avascular necrosis, hopefully you know, that's a very common thing, unfortunately, in the head of the femur, where we lose blood flow to the bone. And so that can then lead to, again, death of the cartilage. Any type of issues where you lose blood flow, small artery or something like that, around a bone can also lead to injury of the cartilage. Small fractures that might actually damage the cartilage at the same time can also occur. Ossification, so where some people, and nobody really understands why, but some people, when there's irregular loading and there's too much shear or rubbing or force on a certain area of a joint, they can develop ossification or bony growth. So this is extra bone that grows. And if that bone grows, again, in the subchondral bone, then that can actually cause injury to the cartilage itself. So as we said earlier, there's limited healing ability for our cartilage to heal on its own. So if any of these things that we mention here have happened to you and you have cartilage injury, because of the lack of blood flow, and you guys will see as we go through all of these postoperative classes that blood flow is our big important thing. And if you don't have good blood flow to the tissue, or if you have some sort of pre-existing disease, or if you're a smoker, all of these things will affect our ability to get good blood flow to tissue, and therefore healing will be much slower or will not happen at all. Also, as we get older, you'll see that cartilage has decreased chondrocyte density. So we talked about how those chondrocytes are there to help design the matrix and provide structure to cartilage. Then those decrease with age. We also have lower collagen turnover. So our collagen type 2 especially is very minimal anyways in cartilage. And so as we get older, we even start to be able, it becomes slower for us to be able to remake cartilage and provide new cells for collagen. We also need to make sure that we have synovial fluid that's coming in, as we said earlier, that's able to come in and provide nutrients and bring the good cells in, the new cells, and bring the old cells out. And so there are different surgery types that we're going to talk about, things like microfracture, that actually help, they think, to bring in new cells. So that's kind of what a microfracture surgery is used for, and we will talk about that. But even other types of treatment that you guys have seen, dry needling, which is basically acupuncture, PRP, which is plasma-rich platelets, those are things that they also think can help develop and bring in those new cells to help with growing new cartilage tissue. So, unfortunately, following certain types of pathologies where maybe there's a tear or a hole in the cartilage, what we end up replacing that cartilage with is what's called fibrocartilage. And that fibrocartilage does not have the ability to absorb shock, and it does not have the ability to be the same sort of smooth surface that the original cartilage was. And so we talked about how important it is for our cartilage to be able to take on all of that power and pressure from the ground as well as from our body, and how important it is to have a smooth surface through our joints to allow for that. But that quote-unquote new cartilage is not as good as the old cartilage. So fibrocartilage, it doesn't have the stiffness or the permeability. So basically, it doesn't allow the same kind of compressive force that the original cartilage did. So you have to recognize that what we're replacing our original tissue with is not as good. And you guys, unfortunately, you're going to see the same thing with ligaments and even oftentimes with tendons. So when we have injuries to ligaments and tendons, what the body then puts in place of those things are not as good as the original. That is not the case, however, with bone. And so what's great is that we're going to see that when bone is healing, that it actually heals stronger than the original bone. So bone's a little bit different, but unfortunately, a lot of the tissues that we have to deal with our patients following an injury and or a surgery, they don't have the same properties that they did before the injury, before the surgery. So how can we help with our patients to allow for better healing and better repair of cartilage? This is the big question. And what we have found is that moderate loading helps with repair. Excessive loading actually causes too much loading on the tissue, which can then lead to the tissue breaking down. So when we say moderate loading, we want low impact activities. We want things like biking and swimming. We do not want things like plyometrics or high impact jumping or running for tissue for this cartilage repair. Insufficient loading, so not having enough loading, definitely has very negative effects. It delays healings and it makes that cartilage even weaker and thinner than it was before. So if you completely immobilize a joint following an injury, then you are not allowing that cartilage to heal. And it's really, really important that we understand that weight bearing and moderate loading are really important for cartilage health. So again, moderate loading, we're talking walking, we're talking biking and swimming, and basic movements are very, very important for our patients following a cartilage injury or a cartilage surgery. So degeneration occurs if they are immobilized. The more rigid the immobilization, the worse it is. So if they're somewhat immobilized, like they have a brace they can take off and then allow for movement throughout the day, then that's better than if they don't. If they're wearing a cast and they don't have movement, or if they're being told they shouldn't move, or if they're fearful of moving, any of those things are going to cause degeneration and make it worse. Weight bearing is very important for cartilage, and you're going to see that with almost every single patient that we're going to talk about throughout this entire postoperative series, doing earlier weight bearing is better for that tissue. And so in the case of cartilage, weight bearing is important. I'm not going to go into a lot of detail on this slide. This talks about the alterations to the cartilage with immobilization. I know it's only in English. What I want you to recognize is that the tissue itself, if immobilized for too long, changes its ability to heal. And I've said that in several different ways, but basically it becomes more calcified. So it has decreased ability to take on shock and absorb shock. There's decreased amounts of collagen, which we know collagen is very important. There's decreased cellularity of the chondrocytes, like we already said earlier, and there's decreased synovial fluid. So immobilization of any type of cartilage injury is not a good thing. Research has showed us that following 6 to 12 weeks of immobilization, articular cartilage degeneration was present for 50 weeks after that. So over a year, basically, you guys, if they were immobilized for 6 to 12 weeks, they basically had problems with their articular cartilage a year later. But if they're only immobilized for 2 weeks, then you can reverse that articular cartilage damage after about 4 weeks of movement. So if they're under 2 weeks of immobilization, you're probably going to be able to help them by starting to get them to move, and that cartilage is going to be a lot healthier. It's normal for our cartilage to change as we get older. What you'll see is by adulthood, we don't have a lot of chondrocytes, like new cells being done, proliferation of chondrocytes. Also, as we get older, the tensile strength and water content decreases. I think what we question these days is this idea of, does everybody get osteoarthritis? And to be honest, I think probably most people do. I think that is normal aging. And as our population gets older and older, it's going to be pretty common for us to see our patients getting diagnosed with osteoarthritis or OA. And what we have to help them understand is it's just like wrinkles on the skin. It's a very common problem that everybody gets as they age, and so it should not be something that makes them fearful of movement. And that's the most important thing, is they need to recognize that movement is a good thing. So osteoarthritis is basically just degeneration of that articular cartilage. Sometimes it can develop bone cysts. So again, that's that extra bony growth, or osteophytes. And then also the joint capsule itself can get thicker. I'm sure you guys have seen pictures of this. You'll see here they always show it as being very red, which I think probably scares our patients. They look at this and they're like, oh my gosh, I've got all this red stuff in my joints. If you were to open it up, it would be all red. And of course, that's not really true, but the artist here is trying to show where the damage of the cartilage is. And so that can happen in the knee, that can happen in the foot, in the ankle, and in the shoulder. Again, all the places that we talked about earlier, the cartilage can wear down, and that's osteoarthritis. So let's just go back and sort of talk about the different types of tissue that we talked about in the introduction, and talk about how we can recognize when that tissue might be damaged and how that tissue responds to certain kinds of stresses. So for the instance of cartilage, meniscus, and labrum, which are the things that we're going to be talking about during this first group of postoperative classes, you'll recognize that compression and torsion are often the movements that would lead to symptoms. So catching, clicking, locking, feeling like the knee is going to collapse. All of those things are things that are generally described for patients who might have an injury to their cartilage, possibly their meniscus or their labrum of their hip, the labrum of their shoulder. For ligaments, it's a little bit different. You're usually going to feel pain and hypermobility, so extra mobility at that ligament. And so the examples, when we talk about ligaments, you're going to have more knee valgus, and that's going to be more of a medial collateral ligament problem. You may have a positive anterior drawer at the ankle because of ankle sprains. At the elbow, you might have increased valgus, which is from the ulnar collateral ligament, and that oftentimes happens with throwers or pitchers. And then from the shoulder, the capsule might be unstable. So those are all kind of ligament issues. And really what you want to recognize is, again, that's sort of a joint laxity, and the end feel is very loose or empty. With bone stresses, there's usually problems with weight bearing. They're unable to bear weight. That's oftentimes something where we can say that's a bone problem. And then with bursa, they're actually going to have issues with compression. So you can press on a bursa and they're going to have pain. So it's a pretty obvious problem. It's a focal tenderness, meaning it's very direct that they're going to demonstrate their pain. With muscle or tendon, they're going to have symptoms reported when they're in a passive stretch of that muscle or tendon, and or when you contract that muscle or tendon. So it's very obvious. I think you're going to be able to either stretch the Achilles or have them do a single leg heel raise, and they're going to demonstrate weakness and or pain, and you're going to know that a muscle or tendon is involved in the injury. Whereas with nerve, and we're not going to spend a lot of time talking about nerve with these classes, but with nerve, they're going to usually talk about tingling, pain, some sort of like lancinating or sharp shooting pain. And you can usually actually provide tension to the nerve or some sort of tapping, compression, Tinel sign to that nerve, and they will be able to reproduce their pain. Specifically with cartilage, they're going to tell you that the pain is worse with torsion, with compression or twisting. They're going to oftentimes complain of catching or clicking sensations or locking of the joint itself. They may complain of instability, but usually they're going to complain more of, again, that locking pain. Oftentimes it's more of an achy pain, but sometimes they will complain of a deep pain as well. And as we do our examination for these patients, we'll be able to actually reproduce that pain or catching or clicking with twisting movements, so compression or torsional movements. So we use things like the McMurray's or the Thessaly test for the meniscus of the knee. We might also use an apprehension relocation test for the shoulder labrum, or things like a scour test, a Fader test, or a Faber test for the hip. And so what I really want you guys to get from this particular presentation on articular cartilage is that the primary goal and use of cartilage is to provide a smooth surface for low friction movement. And so it allows for the bone to not have friction directly on the bone. And instead, the cartilage can take on the load. And so we have loads, again, from the bottom up, from the ground up, and from our body down. And our cartilage is really designed to take on that load with all that fluid there, all the synovial fluid and water, so that our bone doesn't end up getting compression. Reciprocal loading is very important for cartilage. And so this idea of being able to pump the joint and move the joint on low loads is what allows for that synovial fluid to bring in new nutrients and be able to keep healthy cartilage. Remember, the cartilage does not have a lot of ability to regenerate on its own. It does not have good blood flow. We are counting on that pumping motion, that controlled compression to bring in new synovial fluid and allow for the cartilage itself to heal. So these patients are going to come to you and they're going to say they have catching, they have locking, sometimes they have quote-unquote crepitus, and decreased stability of the joint. And so those are the people that we think, okay, this could be a cartilage injury. And so with those people, we want early motion, but limited loading. We don't want to allow too much joint compression or twisting of these joints because that's going to cause more irritability. And instead, we want very basic movements at low loads. As we mentioned earlier, that's swimming, that's biking, that's walking. And those things, as long as they're not causing increased pain, are probably allowing for better healing options for that cartilage. So that is all we have for now. Here's a couple of references related to what we talked about today. We are now going to move into specific pathologies related to cartilage and post-op treatments for those of you who will get to see those patients following a surgery. So it's great to talk to you, and we'll talk again soon.